So after reading the article by Finch about the TRIPP model, I think the components of this are things that we can use in athletic training clinical practice to kind of standardize the way that injury prevention is done. So the TRIPP model is broken down into 6 components. The 6 components include injury surveillance. The first part of injury surveillance is using epidemiology to define and collect the problems that we're seeing within our population that we're working with. So through injury surveillance, we're able to collect the data about what risk factor or what injuries are occurring at what rate, and if they're occurring during games practices for certain genders. And this establishes the epidemiological nature of the disease. The second part is the etiology and mechanism of injury. This is where I think different individuals, including clinicians and researchers, have to come together. So this includes biomechanical analysis of how the injury is actually occurring. It includes case control studies that would be able to be collected from different clinical sites from athletic trainers. And also includes cohort and epidemiology studies where we're able to collect a large mass scale data from epidemiology and a cohort study where we have some ideal situations that tell us the mechanism of injury and the etiology of certain conditions. Once we have step 1 and 2 done, I think we can then go into the prevention development. Until that is done for step 1 and 2, we're not able to do so. So step 3 is prevention development, and this is guided by the steps. So the prevention development takes time, and this is something that the TRIPP article says should not be anecdotal. So this shouldn't be something that is done as clinician to clinician. It should be something that's done in a controlled manner that we're able to assess how well this is working. The article actually suggests using cadavers or simulations to do so, which I think is something that would be really unique in athletic training, to develop injury prevention mechanisms using simulations as a mechanism to do so. I think the idea of simulations currently is through acute care and evaluation, and so I think using them for injury prevention would be such an interesting and different manner of using simulations as an educational technique and a clinical practice technique. Next, the fourth is ideal conditions for the scientific evaluation. This includes completing the actual prevention in a manner that is going to be an artificial environment. So as much as we would like to hope that the developed prevention measures would work, we first have to test them in an ideal environment. If the tests and prevention measures do not fit or come out to be successful in an ideal environment, we would then know that this probably would not be successful in a real-life environment. As such, we have to return back to step 3 in the TRIPP model to then keep investigating it. This includes small lab samples. The issue with that is the complexity of the nature of how injury prevention actually would look. We also have small lab samples, and we look back at some of the other research done on injury prevention. We see that some of these prevention development is done in such small samples of 10 to 15 people in a very similar demographics and white males typically, that we see that this may not always work. Next, step 5 is implementation strategies. This is the part that I actually connected back to the most of this article. This touches on the motivators, the barriers, and the risk perceptions of the individuals. Basically, this whole breakdown is in the resources available and the safety and the development of these prevention. And if people that are in this situation, whether that be employees and workers or athletes, that we are understanding that if they understand the risk and the perceptions or the motivators and the barriers to actually implementing this. Is finance a burden? Is there not enough time to actually do this? Do they feel that they are not at risk for developing something, so they wish not to complete this? I think those are all serious things that we need to consider as clinicians when we start to use these. Finally, step 6 is the evaluative effectiveness of the prevention measure in implementation. This is where you use step 1 and step 5, using the injury surveillance and implementation strategies in a mixed model to then see, does the data and the behaviors actually have implementation to show that the surveillance data on the injury has then decreased as a result of people's different behaviors using the implementation. This is different than the first 4 steps of the other model for injury prevention, where it has establishing a procedure, the etiology and mechanism of injury, prevention measure, and assessing. This takes into consideration how the prevention measure is created and the evaluation in a laboratory-based model and a real-life evaluation model. This is similar to the idea of validation case studies, where we're able to take what we're doing in the literature and actually implement it into clinical practice to see if it's working. As an athletic trainer, though, I typically use injury prevention from the mechanism of is this component or this measure something that can impact the person alone? I typically don't do this on a grand scheme type of mentality, and I think that's something that I need to improve on. So I typically do use injury prevention, but it's very patient-driven rather than a sport-driven mentality. Some of those include addressing FMS deficits and using injury prevention in terms of screening or identifying risk factors for certain conditions and addressing those through exercises that we know would address those through biomechanics research. The TRIPP article has benefits and limitations to clinical practice. I think that the time is a substantial limitation factor in terms of how different all of our patients are going to be, that the idea of being able to translate all of this over a course of time to have something that implements into clinical practice is going to be a very time-demanding task for researchers and clinicians. I think it also requires clinicians and researchers to break down the barrier of one doing one and one doing the other, that we have to continue to work together to make sure that the injury prevention measures are to the best of the ability for all.